Introduction and background. Malaria remains a public health concern for Sierra Leone, where the disease is holoendemic, transmission is recurrent, and the disease accounts for 40% of outpatient morbidity. The disease burden is significant. As of 2016, according to the MIS, only half of all children under 5 with fever were tested for malaria prior to treatment. At the time of this midterm review, the situation had improved from the baseline, according to research findings and triangulated secondary source data. The improvements cannot be attributed to any singular project, but projects like CAAM have supported the MOH's strategy to make an impact in controlling malaria from community to national levels. The Ministry of Health and Sanitation, through the National Malaria Control Program, has led the design and implementation of the national program with clear goals and objectives aligned with the broader health sector strategy and national level activities. However, the linkages from the subnational level activities remain weak, which is where community level activities like CAAM do a lot to bridge the gaps. The CAAM project.
My name is Ibrahim. I am the Global Fund Project Director for CRS, and I have been managing the Global Fund grant, the SAP NFM2 grant, and the currently we're going into NFM3. My job is to ensure that behavior change is promoted to ensure maximum uptake of services that are provided by the Ministry of Health. The Global Fund grant that I manage is jointly funded by the Global Fund, but we work closely with the National Malaria Control Program as an NGO, civil society organization, to support the uptake of services that they are providing. We are working with currently with 3 SRs. Before it was 6, which we reduced to 3 sub-recipients. These are partners that implement the program. The CAAM approach, which is community action against malaria, was born out of an innovative approach born out of intense collaboration and consultation with community members. We know malaria in Sierra Leone is one of the countries where it is high burden. We have 40%, which is far above the WHO threshold of less than 5%. So we are aiming for pre-elimination, and we realize that we need to intensify our behavior change interventions across those areas where we deem as high burden districts. Following the MIS survey in 2016, there are 6, and in some of these districts, the prevalence is as high as 59%, which is unacceptable to us. So we came up with an approach called CAAM, Community Action Against Malaria, which was crafted. It's like old wine in a new bottle. It's a combination of PRAs, this is respiratory appraisal, malaria self-assessment, which was developed by RBM, Pharmaco Initiative, which was a UNICEF initiative, and community participation in general. So this process is a process where the community come into contact with the basic health facility staff and kind of do an in-depth assessment of why malaria exists in their communities. And then they come up with a detailed action plan as to how they can address that activity, the malaria burden, and then they come back to the health facility to really express their report their progress every 6 months. They are also using what we call trackers to track malaria incidents in their communities and track this on graphs and show it to the entire community, so that the entire community can be motivated to work together to address the problem of malaria. The strategy follows data that is generated by HMIS, and this data is what dictates which communities we go to and which communities we don't go to. In other words, we are following communities with the highest burden. First, you go to the highest burden districts in the country, then you go to the highest burden basic health facilities within their catchment area, and then you go to the highest burden communities with malaria within the catchment area.
The Community Action Against Malaria, CAAM, was funded by the Global Fund in response to the need for an acceleration in the management and control of malaria in high-risk communities in the period 2018 to 2022. The project was implemented in 25 communities in Potloko District and 30 communities in Pujaun District, where malaria incidence was at very high levels. The project also reached all the catchment PHUs in the communities, as well as specific schools and community health clubs. The project was implemented in collaboration with implementing partner Breeze Foundation in Pujaun, and direct implementation was carried out in Potloko District. The overall goal of CAAM was to achieve effective reduction in malaria incidence and improve control over malaria through community participatory action in the 2 pilot districts. To achieve this goal, the project aimed to create a platform for effective and efficient community participation by establishing a supportive environment that will promote sustainable behavioral change to fight malaria interventions in their communities, as well as to use the malaria incidence tracker to plot the incidences across the CAAM communities. The project used health clubs and mass media campaigns, the positive deviant approach, and the participatory community goal setting approach. The evaluation purpose. The major purpose of the midterm evaluation was to assess progress and contributions towards project outcomes in line with the objectives defined in the terms of reference. This included assessing the extent to which the intermediate results of the project have been successfully achieved, and critically assessing whether the CAAM implementation in Pujaun and Potloko districts is on track in meeting its objectives. The midterm evaluation provided lessons learned and proffered recommendations for improving program design. It also provided insights into the effectiveness of the community goal setting and positive deviant approaches across targeted communities in the 2 pilot districts.
My name is Mahmoud Kabar, the Monitoring, Evaluation, Accountability and Learning Manager for the Global Fund project at CRS. So primarily our M&E strategy looks at assessing the intervention from the inception stage, reviewing the progress until the conclusion stage, and then trying to derive lessons learned to guide the development of future proposals. So the CAAM approach is devised around enhancing community ownership of the intervention, which include establishing community members that are CAAM members, and then also enhancing the coordination between them and the health facilities within their catchment areas. So the CAAM members hold meetings together with the health facility members to try to look at the malaria prevalence across their respective communities. So meetings are held at community level. In addition, meetings are also held at the health center level. Upon the completion of these meetings, the malaria incidence tracker is plotted to see the prevalence of malaria incidents within that specific community. In addition, the tracker is also plotted at the PHU level, which also record the malaria prevalence across catchment communities reporting to that health center. So the tracker is one of our vital tools that help us in this intervention. Once we discover that the malaria prevalence is either on the increase or on the decrease, CAAM members, together with health facility members, will devise corrective measures in order to turn the rate of malaria, which is most likely on the increase, to reduce it. So this includes enhancing SBCC messaging on our 5 key malaria messages. In addition to that, this intervention is also monitored to try to identify challenges. Once these challenges are identified, the team sits together, develop frequently asked questions, and also provide remedies to prevent these challenges from recurring in the field again. We also devise lessons learned from our intervention. These lessons learned will also aid future proposal development and also guide the team in making informed decision in the current intervention. So all of these also aid the stratification process, because the essence of the midterm review is to identify the gaps and then come up with recommendations to aid the team as we scale up our intervention to the remaining districts.
Key findings. From the baseline, more people are sleeping under a bed net. The midline shows that targeted interventions at community level are working, especially on messaging and overall behavior change communication strategies. In Pujang and Port Loko, there is commendable knowledge, attitude, and practice shift. More people are aware that they need to be protected against malaria. The achievements in malaria control can be attributed to a multi-dimensional effort from international donors, the Rollback Malaria Program, the Global Fund to Fight AIDS, Tuberculosis, and Malaria, the Ministry of Health, the National Malaria Control Program, DDPC, and the Health Education Units. From the baseline, malaria incidence has reduced nationwide from more than 2,240,000 visits to approximately 1,096,000 in the year ended 2020, a reduction of over 51%. Deaths due to malaria reduced even more significantly. At the midline, several indicators improved compared to the baseline. This included children under 5 with fever getting tested prior to treatment, under 5s with malaria who received ACT combination therapy, children 6 to 59 months testing positive for malaria parasites before being treated, 6 to 59 months old children having low hemoglobin or malaria-related anemia, pregnant women sleeping inside long-lasting insecticide-treated nets, and pregnant women receiving doses of intermittent preventive treatment in pregnancy. The strengths and weaknesses of the intervention. The key strengths identified in the CAAM program included the collaborative nature of the project, regular meetings with in-charges, stakeholders, and community members, the free flow of communication to community members, effective advocacy, sensitization, and community awareness. Many respondents point to the lack of incentive structures for beneficiaries as a weakness, as well as the level of monitoring inside communities. The project's strongest assets were considered to be the skillful and resilient staff and the efforts at capacity building for beneficiaries and participants. In terms of the most significant change from the baseline, coordination among community members improved considerably, especially around community goal setting, cleaning of the environment, awareness and knowledge, all as tools to fight malaria. The use of bed nets has increased, especially the long-lasting insecticide-treated bed nets. This have been the result of massive increase in sensitization efforts from CAAM, as well as government efforts in the districts. The CAAM project has given a facelift to the fight against malaria, leading to greater awareness and reduction in cases. The introduction of standardized ACTs at no cost has contributed to correct drug dosage use and reduced antimicrobial resistance in the population. In terms of results achieved, CAAM has improved prevention and control efforts. Effective and functional community surveillance, disease tracking, and incident reporting systems were largely achieved. CAAM committees and trained PHO staff were key to this achievement, although they cannot be solely attributed to them. More than 65% of respondents know that malaria incidence tracking is happening in their communities. From focus group discussions at the MidTerm, it is clear that the CAAM structures were existing and functional and well recognized by the DHMT. Project activities were very successful, including the school health clubs, the community health clubs, the community action committees, the positive deviance section, and the community goal setting. 55 PHUs were assessed using a facility assessment checklist. At the midterm, there had been some progress from the baseline, but more remains to be done in terms of equipping the PHUs and its staff for patient-centered care. Full services are normally available for uncomplicated malaria. Severe malaria, however, could not be handled at 89% of PHUs visited, and in-charges confirm that they normally refer severe malaria cases to the general hospital. There was, however, inadequate service readiness in more than half of PHUs, with some having no or inadequate staff at the facility at the time of the assessment. In terms of malaria incidence reporting and community surveillance, this was a strong positive factor in CAAM. The CAAM committees and their connections with the DHMT was good, and PHU reporting was mostly up to date. In 12% of cases, PHU records were incomplete and some registers were missing, but for the most part, registers were easily retrieved from the stores or from in-charges offices. Maintaining the gains will be challenging, but it can be done. Inadequate patient care, with some PHUs closing down at intervals, inadequate supply of drugs and commodities, inadequate supply of electricity, and inadequate number of qualified staff make the regular running of PHUs challenging when there are no donors involved. The roads can present a significant challenge. Poor road networks in the hard-to-reach PHUs are also an effective obstacle to effective referrals. Port Loko CAAM District. From a summary of key indicators, progress was definitely made from the baseline to the midterm. On knowledge of causes of malaria, the MTR noted that knowledge remains high on the causes of malaria, increasing to 98.7%, with respondents correctly identifying mosquito bites as the primary cause of malaria. Pujaun, similarly to Port Loko on the summary of key indicators. Progress was made between the baseline and the midline. In Pujaun, 97.74% could correctly identify the cause of malaria, up from 92.7% at the baseline. Females caught up with males on knowledge compared with the baseline. There was considerable diffusion of misconceptions and rumors around malaria, with community members attributing the multitude of communication events around malaria to increased funding. Knowledge of symptoms for severe malaria almost doubled from the baseline, from 34.5% to 69% in Pujaun. Conclusions and recommendations. CAAM made great strides in ensuring surveillance structures were put in place to monitor the progress of malaria control efforts in Pujaun and Port Loko. The pilot design was prudent and allowed for lessons learned to be implemented before a rollout to other districts. The evaluation will assist the transition to whole country project implementation. CAAM took advantage of existing community structures as well as the presence of PHU and community health workers in Port Loko and Pujaun. Positive deviants were able to engage community members on behavior changes required for making progress in the fight against malaria. However, if community bylaws are not constantly enforced, there remains the risk of bad behaviors resurfacing, especially where there are no sanctions. Travelers' malaria was very much an issue across the program districts, as well as the two control districts of Kailaun and Cambia. Cross-border migration continues to be a significant threat. A strengthening of the malaria incidence reporting process will enable data and surveillance to be more useful across more communities. The PHUs in the program implementation areas are invariably very far, and many NGOs have concentrated on hard-to-reach areas, resulting in an unintended consequence that many of these hard-to-reach PHUs are targeted by multiple projects. Strengthening the CAAM project must include capacity building at school level for school coordinators of health clubs, as well as empowerment of the positive deviants. In terms of knowledge, attitude, and behaviors around malaria, we conclude that at the midterm there had been progress from the baseline on all indicators mentioned. The positive deviant approach and the community goal setting should now be implemented side by side with the health clubs to ensure an onslaught effect on the malaria interventions in the districts. This video report is an excerpt of the full report. The full midterm review report is available at CRS Sierra Leone. The evaluation was conducted by Ascendant and Company Limited. Evaluation leads were Olufela Adeyemi and Maurice B. Juma. Field work was led by Mohammed Veron Kanu, Pius Yoko, Margaret Sisse, and Tapsiru Sisse. The evaluation is dated May 2021.